Welcome everyone to our cardiovascular imaging conference. And it's a pleasure to start the new academic year with echocardiography and some of the basics of echocardiography and Doppler. I'm Dr. William Zoghbi, Chief of Cardiology here, and it's a pleasure to welcome many of our viewers. I'm very excited that this past week we have exceeded 100,000 followers on our YouTube channels. And this is really a milestone for many people. And actually, congratulations to many people who are involved in education at DeBakey Heart and Vascular Center, all of our faculty, fellows, and certainly staff who make this possible. And we pride ourselves with sharing knowledge in many areas. For those of you who are new to us, we do our grand rounds usually on Thursdays and our imaging conferences on Tuesdays. And the nice thing about it is that these can be available to you at your leisure, so you don't have to do it live. But I think if you're live, certainly you can ask questions that may be lingering in the background. So enough introduction, and let's talk about what we do in these imaging conferences. In the first 3 or 4 lectures, it's important to understand what is the basics of the images that you are basically able to acquire. And I know our fellows, our faculty, converge almost immediately toward interpretation. And I will caution you that you need to understand the basics of how the images are obtained, because then it helps you to be ultimately an expert of understanding artifacts, pitfalls, issues that may come up in the image acquisition. And this is mostly actually germane to echocardiography because you are the person who are acquiring the images by hand, as opposed to be put in a tube where the images are acquired electronically. So it's very interesting that the basic principle of cardiac ultrasound has not changed since its inception in the 50s. You have small waves that are sent. They are beyond the audio range, and that's why it's called ultrasound. So you're talking about megahertz as opposed to kilohertz. And if you want to remember 2 things, the field has evolved because of technology, but the imaging is still the same, meaning if I want to know what the image is like, that's one question of how deep it is in the chest, or if you're a fisherman, how deep it is, where are the fish present. The other is Doppler is asking a different question. So these are the two questions. One, I sent an ultrasound, waves, they reflect back, and I know how deep they are, and I know their structure, so that's one. 2 is, interestingly, I send these waves, and if there is some motion here, blood and tissue, the reflected wave are changed, there's a frequency shift, and that's where the Doppler equation comes on board. So these are the 2 major principles. Okay, so that's what we're going to go through today. Okay, so echocardiography has evolved. Even in my days, we had, I started early days of Doppler, but we had an M mode and 2D images. And so what you see here is a family of techniques: color Doppler, continuous wave Doppler, contrast, strain imaging, speckle tracking, 3D of a prosthetic valve. So the family that we have is basically M mode 2D and Doppler, various Doppler, visualization of flow. Now these are basic principles here. This is a wave. This is the wavelength of the wave, and this is one cycle. The longer the wavelength, the lower the frequency. Why? Because frequency is the number of cycles of this wave, how many times, divided per second. The speed of ultrasound is known in biological tissue is about 1,540 meters per second, quite fast. And they have, you know, when you have a transducer that has all these crystals at the top of the transducer, just like you see here, you can excite it with electricity. You could excite it mechanically, and these are mechanical ultrasound, you're not seeing them anymore. But you excite these crystals that are at the tip of the ultrasound electronically with electricity, and you excite them for just a short period of time. They get deformed, and then when they relax, they emit a certain wave. Okay? So you have a higher frequency if this wavelength is much smaller. You have a lower frequency if the wavelength is much longer, just because of the equation of frequency in relation to the number of cycles. Now, the interesting thing, the properties are similar to that of light, meaning if I have this transducer that is emitting a little burst of ultrasound and it hits a surface, what happens to it? Some of it is refracted, so it continues on, and depending on what it hits, it may change the angulation. Remember some of these, physics early days. And some of it is reflected. The interesting thing is, a little bit is reflected and quite a bit is refracted. Otherwise, you're not going to be able to see the distant structures of your heart. Right? So, still some of it goes further down and gets reflected again. Now, if you go and try to understand what these A mode, B mode, and M mode are, A mode is amplitude. So in the old days, you'll just have an amplitude. That's all what you got. Now, if this is a more reflectant, let's say string or, whatever dot, compared to this dot, what is reflected back has much higher amplitude. And if I flip this angle towards you, okay, it becomes a brightness, right? So what this brightness tells me that this structure, whatever that structure is more reflectant of ultrasound compared to this other one. Take extremes, calcium versus a soft tissue versus almost non-reflectant, which is blood. Now in M mode, M is for motion, so B is for brightness, A is for amplitude, M mode is motion. So if I take this dot, whatever that dot, a piece of calcium that's not moving at all, okay, and then I look at what is going on in it over time, it'll be a dot over time, it will be a line. But if this structure is moving, just like the mitral valve, for example, and if I track it, it's going to go up and then goes down, right? Or whatever it is, motion it has. So you take a look at it here. Is that me or my laptop? Okay. Trying to change it here. So in real life, an M mode would look like this, and I know most of you are familiar with it one way or another. So if I take a look at an M mode of a aortic valve, it opens and then closes. And if it closes and there's some motion on it, it's still a dot. And then when it opens, it almost looks like a box. A mitral valve, remember, early, little relaxation, atrial kick, closed, stays closed. Same thing here. And if I look at the septum, it thickens, posterior wall thickens, and a little bit epicardial motion goes up. Okay? So that's your M mode situation here. How is 2D? How is 2D? Basically, it's an extrapolation of a single view, of an ice-pick view of the heart that you see by an M mode into a field of view. And it could be a sector for echocardiography. Why? because it's built in a way for us to go between ribs, because if I go over the rib, I'm not going to be able to see much. Most of it is reflected back, as opposed to abdominal or carotid, where you see the transducers are linear transducers. You know, you're not a sector, you're just like a box of linear, you know, rectangular or symmetrical one. Why? Because I'm sending the ultrasound straight down as opposed to here in a sector, to be able to avoid problems of imaging through the ribs. So if I stop it, okay, behind the scene, and that you're not seeing, is the way I'm going to construct this image here is, this is one scan line. These are called scan lines that are steered electronically. So one scan line here, another scan line, another scan line. You can have 160 of them or more. You're not seeing them. In the old days, we used to see a little bit of that. You don't see them because of smoothing. Notice another thing, that the scans, since they're emanating from a single area, they get, the distance between the scans is a little wider the further you go out, and therefore your resolution is not going to be as good in the far distant field. But the way the image is constructed is, I have this close to this, close to this, close to all this, and you know, I can how do I reconstruct it? Well, I know the speed of ultrasound in the body. If I send it out and it goes through blood, and then it hits a certain reflectant structure, for it to come back and be, you know, registered by the transducer itself, is going to take some time. And that's how I know depth. Depth is solving an equation of when this reflectant, you know, image came back, how long did it take? Because this scale here, although it is depth, it is solving for the speed of ultrasound in the body, right? So basically depth is the time that it took for this image to come back and be registered in the ultrasound itself, okay? So few things that you need to know as an imager, sonographer, or you know, person, irrespective of using, is a difference between axial resolution and lateral resolution. This is very important. Remember one thing. Axial is you're hitting the structure rather perpendicular, okay? And lateral is the differences between, you know, these, the two dots, if they were in the lateral portion. Always in ultrasound, the axial resolution is better than lateral resolution. So therefore, if I want to image a structure, better to be perpendicular to it for me to have the best resolution. Let's take an example here. If I have two dots like this, and they're the same distance, okay, let's say, you know, one area of the septum and then a little further down in the septum. If I have a higher frequency transducer compared to a lower frequency where the wavelength is much longer, when it's reflected back and registered, in the higher frequency I can separate these two better. If I'm using a very low frequency transducer, I may just get a dot as opposed to two separate dots. And this is where your resolution will come into play, and said, how finite can I differentiate two dots? And in ultrasound, it's sub-millimeter, which is very good, particularly in the axial resolution. Okay? Now, how about lateral resolution? We talked a little bit as to if you're further away from the transducer, these beams, although they can be focused electronically, okay, they're going to be quite wide further down. And lateral resolution, instead of these two dots being stacked one on top of each other, they're on the side by side. So my lateral resolution, can I resolve these two separately, or would one of them be in the beam and one outside? And may not be, I mean, here I may not be able to tell that they're different. Here I will be able to tell they're different because I'm focusing the beam and it's much smaller than the other, okay? So remember, the frequency, axial resolution, lateral resolution. Okay? Just like you're driving a car, you need to know what the instrument controls are for you. We have overall gain, so you can increase the gain. And remember, this is what's reflected back into the ultrasound itself. Time gain compensation. Why is it time gain compensation? I'm increasing the gain at a certain depth. And remember, depth is time, so it's time gain compensation. Lateral gain compensation, reject, you bring them down, compression. Mechanical index, as opposed to all the others, mechanical index is actually the output power. All the others are reflected. So this is not the energy that you're sending. This is how you're processing the signal, enhancing it, decreasing it. You're not doing anything to increase the energy or destroy whatever that, whatever other things that you're doing, okay? So the mechanical index is actually the output power. Mechanical index is peak negative pressure divided by square root of the frequency itself. And where it becomes very important is in the applications of contrast. Why? Because this is the energy that you're spending. Remember, this is the wave itself. So this is one of the megahertz waves, right? So this is one of the waves. During compression, if you take a look at a little bubble, it will be compressed. But during decompression, where this is more negative, you'll have almost like a suction effect on the bubble. And if the mechanical index is very high, you'll destroy it. Okay? So keep that in mind when we get to contrast a little bit, at least what the principles of contrast is. Now, we talked about, I'm sending these brief bursts of ultrasound. And you have to send brief bursts, otherwise you'll be completely confused. For those of you who grew up in different areas where I grew up in an area where I see mountains and I could scream, okay? And I listened to my sound coming back, being reflected. I can tell how far it is. Also, you can tell how far a thunderbolt is by waiting for the time that it takes, right? I mean, that's sound. But just imagine if I keep screaming, I will never hear my echo coming back, so I'll be very confused, right? So here, all these images are sent by bursts. They're called packets of ultrasound. They go packets, and then it goes back, gets reflected. I record it on my same emitter. The same emitter is the receiver, okay? And therefore, I could do that. Now, I could have issues with it. One is the reverberations. This is what you see here. This is a mechanical valve with a lot of reverberations behind it. This is the thrombus on a mechanical valve. Also, at the same time, you can have attenuation, meaning if I have a mechanical valve or a piece of calcium that is reflectant of so much ultrasound, remember, for me to see beyond it, I have to keep penetrating with ultrasound to be able to reflect it again so I can see it. So if my first surface is mostly reflectant of everything else, I'm not going to be able to see below it. And that's why when you have people with mitral annular calcification, when you go to the lab this afternoon, take a look and you'll see a black shadow behind it, right? And then it moves following what this piece of calcium is doing. So and then you know it is highly reflectant. Okay, one area to differentiate calcification in the annulus from caseation, you hear that name, caseation is less reflectant, so you're not going to see this shadow behind it. So that's one area to help you differentiate those, okay? So that's attenuation and mostly reflection, and you see that with calcifications or metallic issues. The other thing is you get a lot of artifact. Okay, how do I make the image? Remember, there is these tiny crystals. There is a casing that closes it, and that's why you're not seeing everything. Then there is the chest wall. Then there is some, fat could be, right? Little muscle. And then you have the epicardium. and all that. So just imagine if some of these ultrasounds are being reflected from any of these structures and back again, and back again, back and back and back and back and back. You can construct, images that are funny in a way and could be not as crisp and clean. And at times you could have mirror imaging because I'm reflecting this circle, let's say the aorta. I could see another aorta down there. Why? Because some of these images are being reflected, and then since they take twice the time that it will put the other image below it. So that's mirror imaging. But here in this picture, I see a lot of artifacts. I can't even tell whether there's a thrombus or not. So this could be because obviously either poor penetration from the chest wall or a reverberation back and forth that is crowding the apex itself. Okay? So for us nowadays, I mean, if you were 20 years ago, you didn't have contrast, but nowadays you could use contrast to do that, right? Another thing, if you see something funny, you either change your transducer, change your frequency, change your angulation so that you try to get away from the areas that are reverberating back and forth between the transducer itself. So if you change frequency, position, if you're wondering whether there's a thrombus, you could go from the apex to chamber, move around to the side, or do a short axis to the apex itself to try to, see whether this is real or this is an artifact. So over the years, and I don't know if Mike Quinones is here, but obviously he's seen even more than I have, but I've actually lived all these guys, okay? We didn't have fully digital system. We had mechanical systems first. We have very high frame rates now with parallel processing. Much better quality transducer are amazing nowadays. Multi-frequency transducers in the old days, and some of the sonographers who have more mileage than others. In the past, if you want a 5 megahertz as opposed to a 2.5 megahertz transducer, you have to change your transducer, put a new one, and all of these were fixed. Nowadays, you have multi-frequency transducers, so with a button, I could change from a dominance of low to a higher frequency, and remember, high frequency gives me better resolution, right? Harmonic imaging, we will talk about. A nice discovery on the way to something else. Tissue Doppler speckled, digital image storage, real-time 3D, all these are amazing things. Okay, harmonic imaging. What is that? Well, think about if I send a fundamental, basically, let's take 3 megahertz. This is 3 megahertz, I'm imaging with a 3 megahertz. If you hit a certain structure with 3 megahertz, interestingly enough, it will resonate. And it may produce multiples or a fraction of the actual frequency. An example of that is if you're a piano player or you're a string guitar player, you can hit it hard, and you know what it does is actually it emits beyond the beautiful, nice monotonic frequency multiple of it. And a simulation with my voice is, right? So different frequencies of it, and that's important to do that. So this harmonic imaging was being developed in the early days of contrast. Why? Because these little tiny microbubbles are very sensitive to energy. And you send a fundamental frequency and they will emit 2 times or 3 times the frequency. So you can differentiate contrast from muscle itself. The interesting thing is a discovery that we never thought that muscle, the myocardium, would also emit harmonics. Meaning if you hit it with ultrasound, it will also produce more than. That's what you see here, okay? So an example on the right side is I'm sending at 2.5 megahertz. Some of these, quite a few of microbubbles will reflect back at 5 megahertz. And I could image at 5 megahertz if I want to emphasize my microbubbles. compared to the muscle itself. There is an advantage of imaging with harmonic is it takes away some of the clutter that I showed you before. Take a look. This is the same image with fundamental, and this is with harmonic. So I'm imaging at 5, let's say, but I'm emitting at 2.5. Okay? So, although not as important, but you need to know that the resolution of the structure that you're looking at is at 5, but not at, it's at 2.5, not at 5. Why? Because therefore my resolution is a little lower. So that's why the mitral valve may look a little thicker than usual, et cetera, et cetera. But this is a trade-off if you use harmonic, and most people nowadays use harmonic because it's easier and you don't go from fundamental to harmonic. So you're sending at a lower frequency, which will give you a lower resolution with the benefit of less clutter, more clearer image, just like you see right here. Okay? Not a beautiful image. We agree on that. And if you use contrast, the image is certainly much clearer, and I can see myocardium, I could see thickening, I could see ventricular size, I could see many other things. I wanted to share with you, and we'll have, a special contrast, a couple of weeks from now. But take a look. The image is not beautiful. This is contrast. But this is contrast with fundamental imaging. So let's say I'm sending at 2.5 megahertz transducer, and I'm listening at 2.5, the same. What do you see? You see that I cannot differentiate well between contrast and myocardium. They're all blurred, kind of, right? So this is the same patient, just with a flip of harmonic imaging versus fundamental imaging. You see a difference? I don't have to explain it to you, but the difference is the signal from the bubbles is much stronger than the myocardium, right? So for you to enhance contrast, you have to image with harmonic imaging, okay? All right, let's switch to other things now. So this first section is all imaging per se. And Doppler is a different section. So remember, imaging is send bursts of ultrasound, process it, know when it comes back, know how much time it takes, so I know where to put it in my image. I could do simultaneous processing, so I can increase my frame rate. You want to as high frame rate as possible, close to 100 even, to almost real-time imaging. And structures that have much more dense, much more reflectant would tell me something about them. They're either metallic or calcifications, et cetera, et cetera. And I can use harmonic to improve my imaging overall. Doppler is a different question, and was, discovered by Dr. Christian Doppler. Pulse, spectral, and color, and then continuous wave, and we'll talk about that. This is Salzburg, where Dr. Christian Doppler was born and did quite a bit of his work. As actually, if you go to Salzburg, which I have been, the place is very close to where Mozart was, and then you'll go to the Museum of Mozart, and it's just a lot of contributions in that city. It really is amazing. So that's what you see. That's what's left from the area there. And the amazing thing is he was able to describe these shifts, Doppler shifts nowadays, in frequency based on the stars and the changes in colors of the stars of motion. So planets and stars. Now, what is the Doppler effect? The Doppler effect is there's a certain frequency that's being emitted by whatever, the transducer. And there is a motion of what I'm imaging. And the motion is changing the frequency of what I've emitted. The interesting thing is that change is much lower. We were talking about megahertz for ultrasound. This is kilohertz. That's why I hear it. It's in the audio range. Okay? So a great example of this is in real life. You know, you just walk outside the streets and you'll be able to do that. There are a lot of examples. We'll talk about them. But basically, if an object is coming towards you, these waves are compressed. Okay? So the frequency increases, and the delta frequency is in kilohertz. And if this object is going away from you, then it decompresses, and therefore the wavelength is longer, the frequency is longer by that much magnitude. Okay? Now, some of these effects you could see. I mean, here, I left this picture, actually. This is a historical picture, handwritten by Quinones. So I left it there probably about 20, 25 years ago when he used to give this lecture. And what you see there is that the frequency shift will tell me about direction. So if I'm looking at the aorta, for example, and I look at that frequency there, you know, the velocity is coming towards me, so it's positive, and if it's going away, is negative. So what is this Doppler equation? The Doppler equation is a frequency shift that we talked about related to the actual velocity of that moving object multiplied by the frequency, the original frequency that you send. Cosine theta is very important because if theta is 0, cosine theta is 1. Or if it is 180, right, is -1, right? So basically, if I'm at 90 degree, I get no frequency shift. If I'm parallel, so as opposed to imaging, remember the imaging said the best visualization is perpendicular to the structure for axial resolution. An example of that is interatrial septum. If I image it from the apical window, at times I may not see even it exists. But my best imaging for the interatrial septum is subcostal because I'm perpendicular to it, or RV inflow. As opposed to Doppler, where I would like to be as parallel, because the more angulation I have, the more underestimation I will have of the frequency shift. You got it? All right. If you're on Fannin, you get out, I mean, an example. It's a very, very nice example that you could share with your friends. An ambulance is coming, or the train is coming. You can close your eyes and you could tell two things. You could tell whether the train is coming towards you or going away from you. Okay? You could tell that. And you could tell also how fast this train is going without you seeing it. That's basically the Doppler equation. So I can tell it's coming, I can tell it's going, because the frequency is very different, the sound is very different. The other thing is, if I'm sitting in my office and listening to this, I'm perpendicular to that, I'm not going to see any frequency shift. So whatever the siren is emitting, it will be almost exactly the same. Got it? All right, so what do we do in real life? In real life, in the old days, the scale was a frequency shift scale. Nowadays, you see velocity. It's already solved for you, provided that your angulation is minimal, right? So it's not including angulation. So you have to work yourself and just to make sure that the images that you acquire have the least angulation. And where angulation becomes important, if the angle is more than 20 degrees, more 20, 30, 40, whatever it is, you're going to underestimate velocity significantly. And that's why it's important, particularly for jets that you have no idea where they're going. Aortic stenosis, you cannot tell which direction. That's why you do multiple windows and you take the highest velocity, which implies the lowest angulation that you've had, right? At times you'll be fooled because I see a jet by color and I put a, you never know which direction this thing is going, but color is probably the easiest one. Once, if you see a direction of a jet, let's say a mitral stenosis, and align yourself, I think this is the one that you'll have the least issues with. So keep that in mind, particularly the ones that you cannot determine what it is. Okay, so let's go through some example. Pulse Doppler, how do you do this? Pulse Doppler, I'm interested in the velocity at that site, let's say in the LV outflow tract. How do I do it? Well, I send a little burst, a little packet. You remember that packet? I send a packet, which is 3 megahertz, let's say. I send it, but I'm interested in that yellow area only. So as a transducer, I keep my ear closed all the time till the distance or the time that it took from the burst of ultrasound to send it to come back, I open my ear and ask a question. How much was the frequency shift? You understand that? So I'm looking for a frequency shift. And let's say I have, here you go, 1 meter whatever, per second or whatever it is. I know what the velocities are doing. And it's not easy because whatever equation you're getting back, you have to use a fast Fourier transform analysis to try to understand what these frequency shifts are and therefore solve the Doppler equation. Okay? So pulse Doppler is actually, I know where do I want to get it. I want to know what the velocity there is. One problem with it, if the velocity is very high, I'm going to have aliasing, what's called, because I won't be able to resolve it. Okay? So this is an example of pulse Doppler in the LV outflow tract. You can see the velocities. The red cells, this spectral display that you see, we call it spectral or spectral broadening here, because here it's not broad, but it gets broadening here. Here meaning all these red cells at that area are going at that speed. But at maximal speed, there's some dispersion. Some of them are going a little faster than other, and this is where you see the spectral dispersion of it. And then flow ends at the end of ejection, and you can have the same thing in the mitral area where I put my pulse Doppler either at the annulus or at the tip to get my diastology or flow. Okay? So what is aliasing? Remember, for me to get this Doppler signal, I have to send a burst. And how fast do I repeat it? I have to wait for it deep enough to come back to me for me to send the next burst. And the third one, and I may do 3 or so to get an idea, a better idea than from a single one. So this is called a pulse repetition frequency. Pulse repetition frequency. If the velocity in the LV outflow tract is very, very fast, I may not be able to solve it because my pulse repetition frequency cannot be that high. Why? Because it's too deep. And this is where you get aliasing. I can't tell the velocities. Same thing when you go, I don't know if you go nowadays, post-COVID, I think you're going, to discos, etc. I know some people right here on the right side are party goers. So you go to a disco, and here you go, you have the strobe light, that's the same. That's your pulse repetition frequency. And at times you may not be able to tell whether the person is going forward or backward because the flash is not fast enough. So your limitation is your pulse repetition frequency for you to be able to solve particularly the high velocities, right? So if the PRF is the pulse rate is less than 2, the polarity is assigned to the upper side, and you start having aliasing. Now you could play a trick, okay, and say I can double that a little bit by changing my baseline shift, I know that LV outflow is going away from my transducer into the aorta. So I don't care about polarity. I just want to know to get it so I can change my baseline shift to be able to get the whole velocity. And this is aliasing. You see that in any high velocity. This is mitral regurgitation. You'll see the same thing in any high velocity that you can't resolve because I don't have the pulse repetition frequency high enough to be able to do that. Okay? Color Doppler is actually a form of pulse Doppler. And it has small gates. You could see them there. I mean, they're just depicted basically. And, you know, the convention is that if it is going away from you, it's in the blue shades. If it is coming towards you, it's in the red or yellow shades. Okay? So therefore, now, I'm not going to be able to use a fast Fourier transform because I don't have time. Just imagine, I have to resolve every little area to tell me where the flow is going. So I get an estimate, autocorrelation estimate of a mean velocity or a mean frequency shift that is occurring, you know, in this area for me to. So therefore, you're not able to see or determine actual velocities. You know, when you alias, right? If it goes above 60, it's gonna, you know, wrap around, and that's why in high jets you're gonna see some aliasing. Okay. So the applications are looking at abnormal flows, mitral regurgitation, aortic regurgitation, and all the others. One thing, the Doppler equation still applies for here. So if I have an aorta, an arch, and a descending, there will be an area where it'll be black because I'm going to be perpendicular to that flow, right? So whenever you see a color, changing color in between black, you know you're changing direction. Got it? So as opposed to, let's take an example of mitral regurgitation, and you know the PISA and all that stuff. In mitral regurgitation, the velocity in PISA starts slow and then accelerates and aliases. I won't be able to, and there won't be any black in between. So it goes from low velocity to high velocity, so there won't be any black in between. Color Doppler is sensitive to gains. So unfortunately, we don't have a button that tells me this is the optimal gain. Usually they're optimized in a way, but ideally you increase your gain significantly when you have a lot of fuzz in the background and decrease it so you don't see the fuzz in the background. That's optimized conceivably for that particular person. So their color maps, frame rate is very important because I want to concentrate on the area of interest. Otherwise, I'm going to spend too much time and my frame rate will drop and I will be stroboscopic as opposed to more continuous flow that I'm seeing. Okay? So this is an effect of a low gain versus high gain. Same patient, right? So just look at that. The aortic regurg looks quite impressive, and this is actually, this is real, okay? I was called to the operating room in the days where we used to man the operating room. You're not manning the operating room, where Dr. Lowry starts a case at 7 o'clock at night and wants to finish at 11. No, but in truth, I was called because a color Doppler was done in the operating room, and the mitral regurgitation looked very impressive. And should we do something about it, yes or no? And the first thing you do is take a look at what is the Nyquist limit. And somebody changed the Nyquist limit, and this is 22 as opposed to whatever it is, 57 that you see here. So if you decrease your Nyquist limit, you're going to enhance the low velocities everywhere. And you're going to alias at a much lower velocity, right? So just look how impressive it looks like to you, as opposed to this is the same patient, much less impressive mitral regurgitation. So you got to be careful about that, you know, and that's why you need to know the basics of ultrasound. Sonographers, interpreting physicians, whatever it is, it doesn't really matter. You have to understand this. So the factors that influence frame rate would be frequency of the transducer, the scan depth, right? So if my scan depth is way down, I'm going to have to wait too long. If it is wide, I'm going to have to process all this information, and you know what happens? Your frame rate will drop down. If the frame rate of updates is less than 15 per second, it will be very stroboscopic, right? So you don't want that. Okay. High PRF, you're not using it at this stage. Basically, you fool the system by saying that my area of interest is very close to the transducer, so therefore I can use a high PRF to resolve it, but you don't need it nowadays with continuous wave Doppler. Tissue Doppler, very important. Tissue Doppler, in the past, we wanted to ignore it. We don't want to see it. We don't want to see it. And the interesting thing is very different than flow Doppler, blood flow Doppler. Why? Because the intensity of the Doppler signal is very high and the velocities are low, as opposed to blood. Intensity is low and velocity is high. So it's very easy to decide, oh, I want to ignore muscle. So all the other pictures that I show you, I want to ignore muscle. I want to concentrate on blood. This one, I'm concentrating on muscle and ignoring blood, okay? So, and then this what tissue Doppler was born, my goodness, 20 years ago or something like this. In the past, we forgot it. The color is colorful, but we're not using it as much anymore. Tissue Doppler we're using a lot, thanks to many investigators, including Dr. Naga, who was actually the first to look at this from a diastology point of view and predicting of pressure many, many years ago, 1997. You got it? So now you could take, I mean, we're not going to spend too much time on this, but speckle tracking, actually I was at the first presentation, I was wowed by it, because in the past it was hard to track where each speckle of the muscle was going during the cardiac cycle. And with this advancement, you could do speckle tracking, and therefore you could evaluate many things. One of them is strain. You use global longitudinal strain. Strain is, what is it? Is a deformation of a structure. So the muscle, let's take a longitudinal strain. It deforms from a resting, conceivably, gets compressed. It's hard to measure it in 3D all completely, so you bisect in a way. It's vectors. So in this vector, it has shortened by about 20%, yet it has widened on the other side. And if it's stretched longer, let's say it relaxed by 20%. So it's the difference of a delta between L and what L0 was at baseline, right? And it's in percentage. And before strain, the only time you could look at percentage of thickening or something is by M-mode or 2D from either you have to measure it, but usually from the peristernal window. From the apical window, you can't measure anything really. But this is, I think, the major advantage of such. Now, in the early days, we used Doppler to do that, changes in V1 and V2, but obviously it would be angle dependent, so we kind of dropped that, although there was a science about it almost 10 years. But it's nowadays is mostly speckle tracking, which is angle independent, right? So you're following the speckles themselves of the structure itself and look at changes from baseline to strain rate. We're not using as much, and hopefully at some point in time, because it is much more noisy, it's the rate of deformation. So here you go. So this piece of muscle has deformed this much. This other piece of muscle deformed exactly the same, but much faster. Tells you about contractility, tells you many other things, but it's much noisy, and that's why we use strain mostly at this stage of the game. All right, and there are different types of strain. Most often that you use is longitudinal strain, but there's circumferential from the outside as to what really happened to the heart and short axis. Radial strain is the movement of the endocardium. Interestingly enough, what happens in hypertrophy? Longitudinal strain decreases, EF increases, could be hyperdynamic, radial strain increases, right? So you trade, because of deformation of fibers, you trade longitudinal strain for radial strain. And nowadays it can be automated, which I think is really amazing. Still needs an expert eye to overlook it, because at times the signal may not be as good, etc., etc. But I think it really is a very quantitative index nowadays that can add to your measurement of, function, of ejection fraction, etc. Digital storage you don't have to worry about because it's already available for you. The beauty of digital storage and previews like this is, remember, if you're going to go and measure, I want to pick the one that is less foreshortened, right? I want to pick, so it is the availability of multiple of these. I usually read on a 9. You guys read on a 4 or whatever. It doesn't matter as long as you look at the whole study and pick the areas that are emphasizing ventricle, atria, RV, function, whatever it is. And I think that's the beauty of it, as opposed to the early days of video where you just can't blink and you keep going and going and going. 3D has the same principle, but instead of just one single plane, multiple planes nowadays. These are actually from the among the first 3D that we've done here, and I left it just for historical reason, April 25, 2003, 20 years ago. And you could see that a volunteer, actually a cardiology fellow, who is a leader in the field of echocardiography, not to be named. Not in this room. All right, so that's the beauty of 3D is, and we're underusing it a bit, and I will push, once we have all, our equipment with 3D, and I think the vast majority are nowadays, is to use it as much as possible and tweak it, because it is not completely automated. You have to work at it, to come up with a good estimation of function, particularly in multiple regional abnormalities of the heart, where even a 2D quantitation may be underestimating or overestimating. And the frame rates have improved significantly. You could do strain with 3D, and images from 2003 to now are like night and day, really beautiful, particularly with transesophageal echocardiography. And look at the depiction of a jet in 3D, and you could take a look at that. And some of the newer 3D modalities have transillumination in it, almost like you're looking at the structure itself. It's really, it's unique because of its resolution, high resolution, in 3D, okay, and real time. You're not going to get it in any other modalities, and that's the beauty of it. Okay, so what I did with you today is go through the basics of ultrasound. This is, I know many of you will take their exams, and I think you should. And I think you should emphasize, go back to some of the basics, particularly when you see things that you're not understanding. I didn't go through everything, but at least give you a big overview. That's, in a nutshell, and a review that I've written many years ago, the history of evolution of ultrasound, still on the basics of the same basics that were back in 1950s. This is the A mode, M mode, 2D, Doppler, color Doppler, TEE, contrast, tissue Doppler, live 3D, speckle tracking, 3D TEE, and handheld devices, where that's the principle is exactly the same. And that's the beauty also of ultrasound. You can miniaturize it so much to be at the bedside and with a handheld device. I usually end it with a look back at Dr. Inge Edler, who is the father of ultrasound. This is 1960, the examination of a patient. And I'll tell you how much have this field evolved. Nowadays, we're going to require our sonographers to dress exactly like this. And this is Dr. Edler. There you go, dipping his ultrasound with a little gel. And we know nowadays that, your best images are not flat on your back, right? But I wanted to see, was the early days of ultrasound, and you'll see, this is it. There you go. That's your A mode, and that's your mitral valve, right? That you could see. And this is how the field was born, and it is amazing of where we are nowadays, you know, more than almost 90 years later. All right, thank you very much. Questions? No questions?
Do you still use fundamental imaging?
We rarely use it, although you should. The question is, do you use still fundamental imaging? If you're wondering about a structure, whether it's too thick, yes or no, you should go fundamental, high frequency. But most often, we're not, for the practical reasons. All right. Thank you, everyone.